what are the superficial infections? To begin with, I'm going to talk about Impetigo. So Impetigo is a superficial bacterial infection caused by Staph aureus and Streptococcus pyogenes as usual. And it's going to present in the form of vesicles and pustules that are going to rupture, and overall they're going to form the classic honey-colored crust. And this is the most common form, and this is also referred to as something called as non-bullous impetigo. As I said already, 10% of the cases of impetigo can be bullous impetigo, and it is kind of toxin-mediated disease, and it's going to predominantly present with flaccid bullae and crusted lesions. So whenever you see crusted lesions, whenever you see this honey-colored crusted lesions, you're going to always think in terms of impetigo, and the usual cause is going to be one of the gram-postococci. And it's quite common in warm and humid climates like in India, especially the coastal areas. And it's quite common in low socioeconomic settings because it's going to spread rapidly when the patients are living together. And it can be complicated by something called as post-streptococcal glomerulonephritis. To be honest, PSGN can be caused by either impetigo or PSGN can be caused by pharyngitis. Pharyngitis is one of the most common causes, but you cannot say impetigo doesn't cause PSGN, even though not very common, but impetigo also can cause PSGN. But remember, impetigo will not result in acute rheumatic fever. Very, very important. Only the pharyngitic strains are going to be associated with acute rheumatic fever. All right. Okay. So now what is going to be the treatment? So first, what about the mild cases? Mild cases, you can just manage with topical antibiotics like bacitracin or mupirocin. And for severe cases, you're going to give oral penicillin group of drugs like Amoxicillin, Dicloxacillin, or even Cephalexin. So simple antibiotics are going to be more than enough. In case for MRSA coverage, if you're thinking in terms of MRSA, then you can start with Cotrimoxazole, Doxycycline, or even Clindamycin. Remember, all of these drugs are oral and they're not heavy drugs either, and they're going to have an excellent MRSA cover. So maybe if you're a little bit worried about the systemic toxicity of the patient and in case of very severe infections, and if you're thinking in terms of MRSA, then probably you can add linezolid also, but that's a kind of a overkill, I would say. Mostly Cotrimoxazole, Doxy, or Clindamycin is going to be more than enough in such cases. You can see the vesicles over here, and you can see some of the vesicles have already crusted, and you can see the honey-colored crust over here. So this is an example of a non-bullous impetigo. All right.